Hello and welcome to another intensive care hotline and intensivecareathome.com live stream. Ask me anything. Life support, ICU decisions, tracheostomy, and everything about intensive care at home. It's all about how to advocate for your loved one in ICU and transition them home on ventilation with tracheostomy if that's what is your situation. I want to welcome you to another live stream. And today we'll go for about an hour, right? And want to welcome you. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. And thank you for joining me. And if you're here because your loved one is critically ill in intensive care or because you're exploring home ventilation and tracheostomy options, this session is for you. Now, we usually go for about an hour here, and I answer all of your questions. And if you want to talk to me directly here, you can connect with me live on the StreamYard link. I'm just posting this in the chat pad. And if you want to send me some questions here, then you can do so. A little bit about me. I've been an ICU nurse and critical care nurse consultant across multiple countries. Through Intensive Care Hotline, I help families navigate the ICU environment, ask the right questions, gain peace of mind, and influence decision-making. Through Intensive Care at Home, we provide high-intensity nursing services and transition patients on ventilators back home from ICU. I'm very passionate about bridging the gap between families and the healthcare system. And I've worked in critical care nursing and ICU nursing for over 25 years in 3 different countries, where I also worked as a nurse unit manager for over 5 years in intensive care. I've been consulting and advocating for families in intensive care with intensivecarehotline.com since 2013. And I can very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com, or you can verify it on our podcast section where we have done multiple client interviews. Now, with Intensive Care at Home, I've been the founder and managing director there since 2012, and I can also confidently say there that we have saved many lives, improved the quality of life for patients and their families outside of an intensive care unit, in a community setting, in a home care environment with quality of life, where all of our clients, have community access instead of living their lives in an ICU, or even worse, would have passed away because ICUs think that long-term patients won't have any quality of life, and nothing could be further from the truth. We have been proving that beyond the shadow of a doubt for over 13 years now. So here's what we'll cover today. And before we go to that, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, share this video with your friends and families, and comment, of course, what you want to see, what content you want me to create. Really, the content here is created by users and by viewers only, and by clients, because you ask all the questions that are important for you, and I will do my best here to answer them. So here is what we'll cover today. In the first 30 minutes, we'll dive deep into how families can advocate, ask powerful questions, and manage relationships in ICU, which is what we're doing at intensivecarehotline.com. In the next 30 minutes, we'll explore how, and then in the next 30 minutes, we'll explore how to transition ventilated patients out of ICU with or without tracheostomy into home care, tracheostomy support, and the model behind intensive care at home, and how it benefits patients, their families, but also how it benefits intensive care units. And as we go along, I'll answer your live questions and show you how you can work with us. We also have a membership for families of critically ill patients in intensive care. Also, I want to welcome the viewers that are watching this on replay, because I know there's always quite a few viewers that watch this on replay that can't make it live. But if you are watching live, please drop in the chat which country you're from, what ICU challenge are you facing right now, and again, hit the subscribe button, turn on notifications so you don't miss any future lives. I'll answer questions as we go along at the end of, if they are off topic. So let's start here. When your loved one is in ICU, families often feel overwhelmed, powerless. They have sleepless nights. And who can blame them? The truth is, you don't have to be passive. With the right questions, clarity, and clear communication of what you want, you can actually influence decision making, reduce uncertainty, and protect your loved one's outcomes. This is the core mission here at intensivecarehotline.com. Now, another huge aspect here at this introduction is that intensive care teams know how to manage families in intensive care. Now, I know how to manage intensive care teams. Now, 99.9% of families of critically ill patients in intensive care do not even think, let alone believe, that managing intensive care teams is a possibility, because they are so emotional, they can't think clearly. When you have a loved one critically ill in intensive care, you have to put your emotions aside, which is easier said than done, and start managing intensive care teams. And if you start managing intensive care teams, you need clear thinking, right? You need clear thinking. So let's look at critical questions to ask in ICU. So essential questions families in intensive care should always ask. Number one, why is my loved one sedated, and what sedatives and opiates are being used? So most families in intensive care watching this would have their loved one being sedated and on opiates and on a ventilator with a breathing tube. Now, there's always the exception. Some patients, some families in intensive care have their loved ones not on sedation and opiates, but that's less frequent than patients in intensive care that are on sedation, on opiates and on ventilation with a breathing tube. And also the patients in intensive care that are not ventilated, that aren't in an induced coma, they're probably the patients that can leave ICU reasonably quickly, which means, the pain and the frustration for families is less compared to most of our viewers here. You're usually here because your loved one is in an induced coma, is ventilated with a breathing tube, and you don't know where to go from here, and you don't know what's next. You are scared, you're frightened, you're intimidated. That's why you're here. Very rarely do we get questions from families in intensive care that has their loved one there that are not in an induced coma or haven't been in an induced coma. So, next question you should be asking is, what is the plan for daily sedation and opiate interruption or weaning? Now, one of the most important issues in intensive care is that if your loved one is in an induced coma and on sedatives and on opiates, you want to minimize the exposure to that. And you want to get your loved one off sedatives and opiates and also off the ventilator as quickly as possible. Because if that can't be achieved, it's going to be really difficult to get out of intensive care quickly. You always want to go back to baseline as quickly as possible. And that's not going to happen if your loved one stays sedated and on opiates and in an induced coma. Also, the longer they stay in an induced coma and on ventilation, breathing tube, the higher the risk for complications, right? So, and you want to minimize complications, of course. So ask them, what's the plan for daily sedation, vacation, interruption, and opiate vacation and interruption or weaning? Also, ask them what sedatives and opiates is your loved one on. For example, propofol in intensive care is short-term acting and kicks in really quickly and also should leave the body system pretty quickly, and patients should wake up reasonably quickly, sometimes within minutes. If your loved one is on midazolam or Versed, that's a very strong and long-acting sedative, so it can take a lot longer to wake up. So you need to ask the right questions here. Same is applicable for when your loved one is on opiates such as fentanyl or morphine. How much are they on? Because they are also strongly contributing to keeping your loved one asleep, right? So next, what are realistic outcomes, expectations, and benchmarks? So what do I mean by that? There's a very high chance that if your loved one is critically ill in intensive care, that the ICU team is giving you the doom and gloom, and they're giving you a very negative snapshot of what's happening, right? So the question is then, do you believe that, or do you go on a hunt and do your own research, right? Now, you are here because you want to do your own research, so that's the good thing. Now, let me start with that 70 to 90% of patients in intensive care actually do survive. But that's not what the ICU team wants you to believe. They want you to believe that it's all doom and gloom and that your loved one will not survive. If they do survive, they won't have any quote unquote quality of life, right? And they're trying to create this extremely negative narrative that you need to counteract from day one. Why do you need to counteract? Well, number one, you don't want to buy into someone else's negativity. Don't let anybody's opinion about something become your reality. That's the best way to approach it. Let me repeat that. Don't let someone's opinion about a situation become your reality. So just because they're negative, you need to challenge that, and you need to challenge that quite rigorously. And you need to start to create your own narrative here. And your own narrative needs to go along the lines of, well, you, ICU team, have a duty of care to keep my loved one alive and make sure they get best care and treatment. That's your narrative, right? So, realistic outcome expectations and benchmarks are that the ICU team needs to do everything beyond the shadow of a doubt to make sure that your loved one gets best care and treatment. How do you know if your loved one gets best care and treatment? Well, you need a second opinion. And you need someone that can handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong, right? So other important points here are that, let me repeat that 70 to 90% of intensive care patients survive. So why would your loved one not survive? The odds are in your loved one's favor. Never forget that. But that's not what the intensive care team wants you to believe. By them dragging things down to the doom and gloom level and to the negative level, they want make you believe that they are in control of the outcome, and they want make you believe that death is the most likely outcome, which makes it so much harder for you to be optimistic, right? And it goes away from what the actual statistics say. The statistics say, the research shows that 70 to 90% of intensive care patients survive. Okay, so you got to create your own narrative and move away from the negativity and the doom and gloom. Also, by the intensive care team talking about only the negatives and doom and gloom and your loved one won't survive. If they will survive, they won't have any quote unquote quality of life. They stay in control of the narrative. They have lowered your expectations. That's assuming you buy into that narrative. There's no need for you to buy into that narrative, by the way. You can create your own narrative. You need to start managing intensive care teams so they don't start to manage you. And by trying to lower your expectations, it makes it much easier for them to look for, it makes it much easier for the ICU team, for you to look at them favorably if things improve. They have been conditioned, intensive care teams have been conditioned to manage their downside. So what do I mean by that? If the ICU team came to you and said, hey, your husband, John, will treat him for 3-4 days, and by day 5, he will walk out of ICU. And then it's not going to happen. You could potentially sue them. Now, let's look at the opposite side of that spectrum, which is if they try to lower your expectation, if they say, look, your loved one is not going to survive. If they do survive, they won't have any quote unquote quality of life. They've lowered your expectations, right? And it's easier for them to stay in control of the narrative. So next, what are criteria for extubation, which is the removal of the breathing tube, potentially a tracheostomy or other interventions? So let's stick with extubation for now. Extubation is the removal of the breathing tube, which would mean your loved one needs to wake up and get weaned off the ventilator and the breathing tube as quickly as possible, right? That should always be the goal, because the longer they stay ventilated and in an induced coma, the weaker they get. You don't want them to be weak, right? Also, the longer they stay intubated and ventilated and in an induced coma, the more challenging it gets to wean your loved one off the ventilator and the breathing tube. So, your number one question, one of your first questions when your loved one is ventilated with a breathing tube is, are they doing everything beyond the shadow of a doubt to wean your loved one off the ventilator and the breathing tube? Are they doing everything beyond the shadow of a doubt to avoid a tracheostomy? Right? Because if your loved one, for whatever reason, cannot be weaned off the ventilator and the breathing tube, they might need a tracheostomy. But before you even go there, are they doing everything beyond the shadow of a doubt? And how would you know what that means if they're doing everything beyond the shadow of a doubt? Right? Again, that's where we come in here at intensivecarehotline.com, where we, ask questions on your behalf, where we look at medical records, talk to doctors and nurses directly. That's what we can help you with here very quickly. Right? Very, very, very quickly. Next, how is communication structured? Who is the decision maker on the care team? Dive into each briefly. Ask them, who's the decision maker? Right? So if, for example, the ICU doctor is saying, well, I'm calling the shots here, then you should be communicating with that person. But you should also, talk to other health professionals on the multidisciplinary team within the intensive care team. So, for example, you will find that, nurses, and I'm generalizing here when I'm saying that, but you will find that nurses are more family focused than the doctors. You will find that if you get any support from the team there, it's often from the nurses, right? They are trying to walk into the family's shoes even more so than the doctors. I am generalizing here, but, as nurses, we often take the family's perspective on stronger than the doctors, who are often seeing it from a scientific point of view only. So, next, let's talk about sedation and opiates again, and the weaning process to move towards ventilation, extubation, right? Removal of the breathing tube. So, in an ideal scenario, the clinical roadmap for extubation is wake and wean, right? Wake a patient up, wean them off the ventilator. That's an overly simplistic view of how to get a patient off the breathing tube. The bottom line is, sedation needs to be reduced, opiates need to be reduced as quickly as possible. Let's just take a patient after open heart surgery. Patient after open heart surgery comes back from the operating room, from theaters, and they've just been through 3, 4, 5 hours of open heart surgery. They've been on a bypass machine so that the surgeon can get access to the heart. Lungs would have been deflated during surgery, then they would have been reinflated after the bypass machine, i.e. ECMO, would have been disconnected. Patients can be hemodynamically unstable, they can be labile, because they just had open heart surgery. So what could that look like? That could look like patient is hyper or hypotensive. Often they're hypertensive even, which means they're needing vasodilator, such as GTN or SNP's sodium nitroprusside. But they can also be hypotensive, low blood pressure, then they need vasopressors or inotropes. The heart may also be weakened depending on what type of open heart surgery they had, and they might be on an intra-aortic balloon pumps to support the heart, right? Or they might be straightforward, which means they're not bleeding, they are in a stable heart rhythm, their blood pressure is fine, they're not bleeding, there seems to be no signs of complications. That means you can switch off sedation, you can minimize opiate use. You will need some opiates simply because open heart surgery is very painful, right? The chest is getting cracked open. Let's call it for what it is. And then, you can try and wake a patient up overnight and ideally extubate them in the morning. That's the ideal scenario, right? That's assuming patient is waking up normally, they obey commands, they open their eyes, they can follow commands, and they can breathe up. You can change them pretty quickly from a controlled ventilation mode such as SIMV or ACV to a CPAP or pressure support ventilation mode, and then you can extubate them, assuming blood gases are fine, and like I said, there's no signs of complications. That's the ideal scenario during or after open heart surgery. Now let's just look at an example where things may not be as straightforward. Also, let's stick with open heart surgery. The patient comes back, is ventilated, on sedation, is on opiates, might have had a cardiac arrest during surgery, God forbid, might be on inotropes, vasopressors. Now, there's also a higher incidence of bleeding, the chest drains are pouring out blood, right? Things are not looking that great. Blood transfusions are being started. the heart's weakened, they're on an intra-aortic balloon pump, they have a Swan Ganz or a PA catheter to check cardiac output and cardiac index quite frequently. And the patient is very labile and unstable, right? It could be days until you can even attempt to wake up the patient, depending on how they're going. Have they stopped bleeding? Are they hemodynamically stable? Are they in a normal, regular heart rhythm? Are there no arrhythmias? Right? Is pain controlled? Because they had a cardiac arrest, did they have have they sustained an anoxic or a hypoxic brain injury? Has a CT scan of the brain been done? An MRI scan of the brain been done? Is an EEG necessary? That's what we might be looking at on the other end of the spectrum in terms of complications when things are not going well. Right? So, if things are not going well and the patient remains ventilated, intubated, hemodynamically unstable, and can't wake up for whatever reason, after about 10 to 14 days in intensive care of ventilation and breathing tube, a tracheostomy needs to be considered as a next step. So what's a tracheostomy? A tracheostomy is a breathing tube that's inserted into the patient's neck instead of the breathing tube in the mouth, so that mechanical ventilation can be continued and weaning can be attempted in a more tolerable fashion, because a tracheostomy is much easier to tolerate than a breathing tube. No more sedation or opiates needed. For any one of you watching this that has a loved one in intensive care with a tracheostomy and they're still on sedation and opiates, ask them to switch it off. Ask them to switch it off. Ask them why your loved one is sedated and on opiates potentially. The whole goal of tracheostomy is to minimize or stop sedation and opiates. Right? It's the whole goal. And I can tell you so many stories where, we've either helped families to avoid a tracheostomy by holding ICU teams accountable to move towards extubation, right? Move towards extubation instead of doing a tracheostomy, right? And accelerating extubation, right? Also, what families in intensive care don't know is, let's just say there's a potential for extubation, but it's risky. It could either go well or it could fail, right? If that's what intensive care teams are telling you, then, they're only telling you half of the story. And this is something I found over and over again when we work with families in intensive care, when we look at medical records in particular, or when we talk to doctors and nurses directly. I'm finding that ICU teams are only not even telling families half of what's going on. So what I mean by that is, they're telling you what they want to tell you without giving you all the necessary details that only an ICU professional like myself can decipher, right? So, we have turned so many situations around where families were gobsmacked, where families were literally gobsmacked by the lack of insights they have, also by things that were deliberately withheld from them and didn't further their cause by withholding that information. So that's, it is so important that you and your family are getting access to medical records day one, and that you have a professional like myself and my team review them, right? I'll give you another example. Not only have we helped patients to avoid a tracheostomy and be successfully extubated. We've also helped countless families, after they did have a tracheostomy, to keep their loved ones in ICU for as long as it took to get them extubated or get them off the tracheostomy, right? I mean, we're talking in results here, right? Don't know many people or organizations that can get results for patients in intensive care as an external advisor. So, also let me address some roadblocks, common roadblocks, what to do when doctors say no. Let's just say when doctors push for a tracheostomy early, or when they say, we'll decide, or when they limit visits, or avoid full explanations, right? And these are all scenarios that can be prevented or managed if you know what to do, right? So when doctors are pushing for tracheostomy early, your first question needs to be, are they doing everything beyond the shadow of a doubt to avoid a tracheostomy and try and get your loved one off the ventilator and the breathing tube and extubate them? That needs to be one of your first questions when you have a loved one critically ill in intensive care, right? Also on that note, like I said earlier, you need to get access to medical records ASAP. Can't stress this enough, that you need to get access to medical records ASAP. And get a second opinion, have someone review those medical records for you. I can't tell you how many families in intensive care come to us when it's too late. Don't be that family. Don't be that family that gets walked all over, pushed all over. Don't be that family. If doctors say, we'll decide, we'll make decisions, well, ICUs and hospitals are extremely good to pretend that they can do whatever they want. Let me repeat that. ICUs and ICU teams in particular are very good at pretending they can do whatever they want. Well, nothing could be further from the truth, right? You as a family have rights, right? You have rights and you should exercise them, right? Because if you can't exercise your rights, what's the point? But you do have rights. But ICUs want to make you believe you have none, right? So get your rights in order. You can pretty much challenge anything. And you don't have to use a lawyer or go to court. We can help you challenge just by, we as clinicians, we can easily challenge, right? Like I said, we have saved so many lives for our clients over the years, and you can verify that on our testimonials section at intensivecarehotline.com, or you can verify it on our intensivecarehotline.com podcast section where we've done client interviews. But I can't stress enough how important it is for you to get access to the medical records. I cannot stress that enough. So, how are decisions made when to do a tracheostomy, when to extubate, when to potentially start talking about end of life? Well, decisions should be made by looking at clinical evidence, but the bottom line also is that decisions are often made by artificial timelines, i.e., if a patient hasn't woken up after 3 days, 4 days, some ICUs might say, well, your loved one will never wake up, and if they do wake up, they won't have any quality of life. We should just stop life support, withdraw treatment, and let your loved one die because it's quote unquote in their best interest. Well, not so fast. Not so fast. The first question that I would ask if the ICU team says something like that is, what's the rush here to kill my loved one? Why is there no rush to save my loved one's life? So turn it on its head. And I can also tell you 3-4 days in ICU is not a long time. It's not a long time, right? And unfortunately, decisions are often made in ICU according to bed management issues, financial pressures, staff issues, i.e. not enough staff, whether doctors, nurses, physios. Most ICUs are chronically short-staffed, right? Most families in intensive care wouldn't know that, right? And again, it's also about the narrative. ICU teams, generally speaking, want to decide who can live and who can die, right? So it's really important that you challenge from day one. It's really important that you question everything. And it's really important that you get access to the medical records and get a second opinion. Once again, you are in a once-in-a-lifetime situation that you simply cannot afford to get wrong. And let me repeat that also. The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care, right? That is your biggest challenge. But it's also important that you question everything. And if ICU teams come to you head on and say, you know, your loved one won't survive, if they do survive, they won't have any quality of life, you need to immediately challenge that and say, well, you have a duty of care. And what are you doing to keep my loved one alive and improve their situation? What do you do to help my loved one survive and get the best possible outcome? Before we shift gears into home ventilation and ICU exit options, a quick reminder: if your family is overwhelmed or you want one-to-one guidance through your ICU journey, medical record reviews, coaching, or more, you can work with us here at intensivecarehotline.com. I have a membership for families of critically ill patients in intensive care, and also one-on-one consulting options that many families in intensive care simply find irresistible and invaluable. Once again, just have a look on our testimonial section at intensivecarehotline.com, or have a look on our intensivecarehotline.com podcast where we have done client interviews. Now, in the meantime, if you have any questions, type them into the chat pad or connect with me live here on the StreamYard link. The link is in the chat pad. Now, let's shift to how you can bring ventilated and tracheostomy patients at home, or explore home nursing as an extension of ICU level care. So we just covered powerful ICU advocacy, consulting, and ICU strategy for families in intensive care. Now, if your loved one is on ventilation and long-term ICU stay is looming, that includes often ventilation and tracheostomy, but also could be LVAT, RVAT, inotropes, long-term inotropes, such as milrinone, dobutamine. There is an alternative by transitioning to home with intensive care at home nursing support. That's obviously where intensive care at home is coming in. Because with intensive care at home, we're offering high-intensity nursing, ventilator and tracheostomy care, non-invasive ventilation, home TPN, home IV potassium, home IV magnesium infusions, as well as central line, PICC line, Hickman's line, and port management at home. It is a genuine and legitimate alternative to a long-term stay in intensive care. It's not just theoretical. It's not just a fancy name. It's built on 24-hour ICU nursing support, clinical oversight, collaboration with hospitals, and a focus on quality of life. also a focus on saving cost for intensive care units. As a matter of fact, saving significant cost for intensive care units, because we are cutting the cost of an intensive care bed by around 50%. So let's do the maths quickly. An intensive care bed costs around $5,000 to $6,000 per bed day. Intensive care at home costs around 50% of that, right? So think about that. That saves the healthcare system half of the cost, right? And it frees up the most sought after bed in a hospital, which is the ICU bed. Once again, it's clearly a win-win situation, right? And, life only ever works if it's a win-win situation, right? So how do we make that happen? How do we get patients from an intensive care unit to a home care environment? Well, I'm glad you've asked. First of all, we're making an initial assessment, whether it's feasible, whether it's possible, clinically, of course. Then we look at discharge planning, what needs to happen to get your loved one home, what equipment needs to be put in place, how many staff are needed. For a 24-hour roster, I can tell you we approximately need 8 to 12 staff, depends a little bit on location. We set up the equipment, we start hiring teams or a team for a particular client. We look at obviously emergency protocols, care plans, work with OTs, work with physios, work with speech therapists, work with doctors, nurses. Just recently we've transitioned a patient from an ICU to home on BiPAP with motor neuron disease, BiPAP PEG tube. It's all possible. We've transitioned many clients home from ICU, adult and pediatric ICU, to a home care setting with CCRNs and ICU nurses in the community. We're also now using our own ICU consultant to help with that transition, right? And the good news is more and more ICU units are coming to the party, for lack of a better term, and understand that this is not intensive care at home. It's not a fancy name. It's not a marketing gimmick. It is a real thing. So generally speaking, who's a candidate? Patient needs to be medically stable ventilator settings, ideally no inotropes, even though we could run low dose inotropes at home as well. There needs to be a manageable complexity. For example, if, God forbid, someone goes into ICU with multi-trauma after motor vehicle accident or whatever, that is not an intensive care at home environment. Intensive care at home environment is usually if someone's been in ICU for many weeks or many months, they're either ventilator dependent, they have a tracheostomy, or they're tracheostomy dependent without ventilation. They might be on TPN, they might be on dialysis, long-term dialysis. Which are the contraindications really? What are the contraindications for intensive care at home? It's mainly hemodynamic instability and vasopressor or inotrope dependency, especially if they are high levels, or if someone is awaiting surgery. Also, how do we evaluate risk versus benefit? So let's just take this patient that we took home recently from ICU. What were the risks to keep her in ICU? Well, the biggest risk was infection risk, right? I mean, it is so much more likely that a patient in ICU is ending up with another infection because they are not in a clean environment. They're quote unquote in a dirty environment, right? With other infectious patients in the ICU, right? So that's a risk. And it's probably the biggest risk. But then another big risk is ICU delirium, ICU psychosis, patients not having any quality of life in ICU, families not having any quality of life in ICU. We are talking about a holistic care model here. Intensive care at home is a holistic, all-inclusive care model. We're not only looking at a patient's diagnosis, we are also looking at their social environment. What do they need to go home? Has the family benefiting from going home? How is the ICU benefiting from going home? By freeing up the ICU bed, right? Freeing up the ICU bed and cutting the cost by 50%, right? Another question that we always get is intensive care at home available in my area? So with intensive care at home right now, we're operating all around Australia, in all major capital cities, as well as in all regional and rural areas. So location has never been an issue for us, and here is why. It really depends on, can we find staff? And so far, we've always been able to find staff. Sometimes they can be, even in remote location, fly in, fly out arrangements, drive in, drive out arrangements, depending on the location. But location has never been an issue for us. But location is an issue for patients and families, especially if they are, let's just say they're somewhere in country Victoria, country New South Wales, country Queensland, and they're stuck in an ICU in Brisbane, in Sydney, in Melbourne, and they're hours and hours away from where they usually live. And their families are hours and hours away from where they usually live, right? So, location has not been an issue. Now, next question, has funding been, who's funding all of this? Who's paying for it? Well, before I go into this, first of all, let's think about the mechanics of this before we go who's paying for it. Like I said, the ICU bed costs $5,000 to $6,000 per bed day. Intensive care at home is 50% of that cost. Do you think that someone would have an interest in slashing the cost of an ICU bed by 50%? It's a clear hell yes. It's not even a hero there. It's a clear hell yes, right? If you buy apples at the grocery shop for $10 a kilo, and someone is selling you the same apples for half of the price for 5 kilos, the same quality, the same apples, would you say yes? Right? Of course you would say yes. Right? And on top of that, the apples are being delivered to your home for half of the cost. Because that's basically what we're doing here at Intensive Care at Home. We're delivering the intensive care into your home for half of the cost. So, of course, there's appetite and interest for someone to pay for this. Clearly. So, who's paying for it? So, some of our clients are NDIS funded, National Disability Insurance Scheme. Some of them are TAC funded, Transport and Accident Commission. Some of them are DVA funded, Department of Veteran Affairs. We've had some private health insurance funding, some Department of Health funding. But your biggest concern should not be who's going to pay for it. Someone will. Because if that wasn't the case, we wouldn't exist. Our clients wouldn't exist. Right? So Be less concerned about the mechanics and just start putting the mechanics into place, and we can help you with that. We will be the facilitator. I'll give you another hint here. When we first started out in 2012, I realized hospitals weren't biting, they weren't interested. Departments of health weren't biting, they weren't interested. But I tell you who was interested. You were interested. You watching this, families in intensive care. And that made all the difference. That made all the difference. You as a family have way more power than you think you do. Way more power. Believe me, trust me on that one. I can tell you that when we had clients pass away over the years with intensive care at home, it was often due to lack of funding, but it was also due to lack of family advocacy. Families were intimidated by the authorities. Well, what have I been saying here for over a decade on this channel? Do not be intimidated by anyone. Right? Because the minute you are, you'll pay a heavy price. And the clinical condition for our clients is fairly similar. They need a ventilator, they often need a tracheostomy, or the other way around, need a tracheostomy. Sometimes they don't need ventilation, sometimes they need ventilation, don't need a tracheostomy. But the bottom line is this: all of them need 24/7 critical care nurses at home. And that is actually, by the way, evidence-based. So you can look up on our website the mechanical home ventilation guidelines, which is evidence-based. The mechanical home ventilation guidelines, which are evidence-based, are a result of over 25 years of intensive care at home nursing in Germany, and also a result of intensive care at home nursing in Australia since 2012. Right? So what we do is actually evidence-based. We are also accredited, third-party accredited for intensive care at home nursing. No other provider in Australia has achieved a higher level of accreditation than we have, has policies and procedures for intensive care at home, has built all the intellectual property around that. And that enables us to employ hundreds of years of critical care nursing experience combined in the community. No other provider brings a higher skill level into the community than we do. Right? I want to come back to, again, this client that we took home recently, just in the last 2 weeks, really, was in ICU for 4 months, right? A young lady, desperate to leave ICU, to go home with her kids, 3 and 4-year-old children, with her husband, and we've managed to achieve that now. ICU was also desperate to free up their bed, by the way, right? It was a private ICU and they were losing money. Right? Worked in ICU long enough to understand how private ICUs work. Right? So there's nothing that can't be done if your loved one is stuck in ICU. There's nothing that can't be improved. A lot of it can be improved. So we're going to wrap this up in about 5 minutes here. If you have any questions, this is your last opportunity to type your questions into the chat pad or quickly connect with me here live on the StreamYard link. But, plenty of patients we've taken home after, ventilation, tracheostomy in ICU. Some of it can also be palliative care, end-of-life care. We've done that too. So a lot more is possible than you think there is. Don't put your head in the sand. Don't give up. Plenty of case studies out there how lives can be saved, lives can be improved. Right? Don't let anybody else tell you anything else. Always believe always believe. Always believe in possibilities. Don't let anyone slash your possibilities. Don't do that. So, then I hope that's given you a good overview that you have way more control and way more power when you have a loved one in intensive care, critically ill, than you think you do. And that ICU wants you make to believe, right? And also want to quickly focus on, there's services at home that we provide for home TPN, for anyone needing TPN, which is IV nutrition. We can provide that as well. So let's wrap this up here. So with intensive care at home, we're providing a genuine and legitimate alternative to a long-term stay in intensive care with our critical care nursing team at home 24/7. It improves the quality of life for patients and families. It frees up ICU beds, and it cuts the cost of an intensive care bed by around 50%. Furthermore, we're also providing level 2 and level 3 NDIS support coordination. We're also providing TAC and WorkSafe case management with intensive care at home. With Intensive Care Hotline, we are providing consulting and advocacy for families in intensive care. We have turned so many situations around, you won't believe it, have saved so many lives with our consulting and advocacy, and I feel extremely proud of that. Feel extremely proud of that. And you can, again, verify that on our testimonial section at intensivecarehotline.com, and you can verify it on our intensivecarehotline.com podcast section where we've done client interviews. Now, I offer one-on-one consulting and advocacy over the phone, Zoom, WhatsApp, whichever medium works best for you. We also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecaresupport.org or if you go to intensivecarehotline.com and you click on the membership link. Now, if you like my videos here, click the like button, click the notification bell so that you don't miss any of these live streams or any of my updates. Subscribe to the YouTube channel, click the like button, click the notification bell, and share this video with anyone that can benefit from it, who has a family member in intensive care. I'm sure they will benefit from this video. Thank you so much for watching. We will talk again next week, same time, 10:30 a.m. Sydney, Melbourne time, 7:30 on a Sunday, 7:30 p.m. Eastern Standard Time on a Saturday evening in the US, Canada, which is 4:30 p.m. Pacific time, US, Canada on a Saturday. Take care for now and have a wonderful weekend and a good week ahead.